Okay, that looks like everybody. So I'm going to start with just some little reminders and all that good stuff, and then you all we can start talking about. We have some questions. So I'm going to start by talking about the purpose of the discussion and the intended outcome. And my apologies if this feels duplicative of what Jamie just said, but sometimes it's helpful to hear things more than once. So the idea is that each of the breakout groups is going to get to talk about each of the models. You all will stay in this little room, and the facilitators will rotate, so that I'm going to be talking with you all about option B. I will then go away, and somebody else will come in and talk about one of the other models with you. So as you saw in reviewing the video that we sent, with all three approaches, the inputs that drive the analyses are really what we're thinking about in terms of who's going to be covered, what's covered, et cetera. So I'm going to be asking some specific questions about your perspectives on these inputs, so that Optimus can do its calculating. Some, but not all of the questions that I'm asking in this breakout discussion relate to both the universal models, and some questions are just about this model. So my role as a facilitator is really to try to get feedback from all the participants who want to contribute, and that might mean kind of bringing us back to the main conversation if we get too far afield. Just wanting to make sure that people have a chance to weigh in on all the things that we're getting to. So apologies in advance if I say, okay, let's come back to the main discussion. So to make sure that we have information that is actionable for the analysts, we're going to ask that, I'm asking that you be as concrete as possible. So for example, feedback like cap premium contributions at 5% of income is really actionable. It's really specific, right? And have affordable premiums is less useful information, because what you think is affordable and what someone else thinks is affordable might not be the same. So now I'm going to just say what the model is again, and before you all kill me, then we can get into some questions. So under this model, all permanent Washington residents receive health insurance coverage through a single statewide plan. The state delegates most of the financial risk and payer-related functionality and delivery system management to private insurers. So there's a single source of coverage, a single benefit package that's administered by multiple insurers, multiple organizations. Providers are private, as they are now. This model could either be seen as an end state for the state, or as a transitional model as the state moves to a fully state-run model in the longer term. So it might be, you could think of this as option B is where we would end, or option B was on the way to option A. And the model partially protects the existing infrastructure in terms of jobs, technology, boots on the ground experience from insurers, et cetera, but also preserve some of the market fragmentation that exists today. So I wanted to start by getting you all to talk some about Owen. So I have a little, I don't know whether or not this is going to be useful for you to all see it, but I'm going to share the notes that I take on the screen, because we obviously can't have a real whiteboard. So if I can figure out how to do that. There we go. Okay, so I'm going to start with questions about cost sharing. And these first few questions really are about both this model and the option A, other universal healthcare model that's state administered. And I'm going to ask some questions about beneficiary cost sharing, which can include both monthly premiums as well as costs for using care, annual deductibles, copays, et cetera. So the first question that I'm interested in getting folks to weigh in on is whether the model should include some form of cost sharing by the people who are using it, by the people of Washington, and why or why not. Um,
Nora, are you asking about point of service cost sharing, premiums, or either?
Either. So I'm never working for you. What are oops, let's get that back. Both types of cost sharing. Looks like Kirsten is being super polite and has her hand up.
Oh, you want us to do hands?
I mean, I'm flexible, but I just want to reward the like. Kirsten, did you want to? Yeah.
Yes, I wasn't sure how to do this the best way. That's the downside of Zoom for me, is that it's very easy to just start talking over each other, because you don't really have that direct visual, you know, to see if someone is starting to say something. And some of us have a delay as well, you know, how the audio comes over. But I would be very interested to look at the Medicare cost sharing structure as an example for that. I think is a good starting point to look at something that could be both affordable for people and reasonable as far as deductibles, premium costs, and co-insurance goes. Thank you.
Sorry, I'm muting myself intermittently so that you don't have to hear my my type. But Pam, you want to?
Thanks. Now, thanks for reminding us about raising our hands. I think there should be cost sharing. I think it's. I know it's the world was nicer when we didn't have it, but it's been well established that it spreads costs appropriately, and it also has some impact on appropriate utilization. And the experience from the exchange is that cost sharing should be standardized. If it's not standardized, then it tends to become unaffordable. And it's just like you standardize benefits, you can standardize cost sharing so that you can maximize value and impact consumer behavior to promote healthcare.
Great. Thank you. Erin and then Kirsten. Oh, I missed whether Carrie or Kirsten went first. Sorry. Hey, Jared, will you watch who's going first? Because I keep typing and watching my screen. Thanks.
So I have a slightly different view than my friend Pam. I think that income-related premiums would be reasonable where 0 is what people at whatever the lowest income tier we could define would pay in premiums. And I think point of service cost sharing should be very judiciously used only when the science is clear that the cost sharing, the benefits of the choice that the cost sharing drives outweigh the costs, and the costs are generally, and I think this is pretty well established in the research, the cost is avoidance of care that's useful. And I think except again in some exceptional circumstances, people are very poor judges of what is useful care and not useful care for them. So unless we're damn sure that the point of service cost sharing is driving in the right direction, I think we should avoid using them.
I have just a clarification. I don't think we're very far apart, really. Erin,
I didn't expect so, Pam.
But is this to replace federal programs such as Medicaid?
That's what this model is, right? Oh no, this is 2.
The main model would, and the variant would would keep folks with Medicaid, Medicare, et cetera, out and in their current program.
Okay, because that resolves a lot of the anxiety about low.
Yeah.
Okay, so I see,
Okay, I think that might be.
and then I just saw Peter literally raise his hand.
Yep. Hey, so this is Rochelle. I'm happy to kind of help organize this. So I think what I'll do is I'll keep an eye on the hands. I've got that option open on my screen, and I'll just call on folks as we wrap up the conversation. It's time to move on to the next person. I'll just call on that person, and we'll just do it that way. It's a little bit structured, I apologize, but I want to make sure that we all have a chance to talk. So the next person up is Carrie McKenzie.
Hi there. I wanted to, in all the models, but I believe we're on option C, right? The third option, right? Or no, which one are we on? We're on 2. Okay. I thought we were in 3. 2. Okay. So it's the same though, which is employers include health benefits as part of compensation. So I want to be really clear about what we're asking employers to pay as part of this. And if their cost sharing is reduced, how does is the salary increased in order to cover the cost sharing that they're no longer participating in? What does their participation look like? And I want to make sure we're clear on what that is.
And do you want to let us know what your perspective is on it?
My perspective is it's part of as we make this transition, employees should not lose their total income because now benefits are being shifted and in potential is shifted back to them versus the employer. So we want to make sure the employer-employee percentage on benefits for total compensation stays roughly the same.
Okay, so next up we have Kirsten Powell.
Yeah, I just wanted to clarify on my comment there that would be variant 1.5, or no, variant 2.5, that Medicaid, Medicare, and other federal programs are intact. Because otherwise I agree with Erin that we would need to look at some kind to make sure that people that really are low income are still able to afford health insurance. So I should have clarified that. And also, I think it's important to have some kind of cost share in place because people put more value on their health care, is what I've seen and heard and experienced, if there is some kind of participation on their side.
Great, thank you.
All right, and Bevan McLeod. I hope I pronounced that right, but you're up.
McLeod, but thank you. Can you guys hear me?
Yes, thank you.
Thank you. So first I have a question, which is, does this model, is it based out of social determinants of health? And if not, how do we incorporate that into this model? And I think the second piece of this to me is, so I think the less insurers participating in this, probably the better, at least when you look at cost per person, right? When you expand the risk pool, the cost per person goes down. So I think if we lower the numbers participating in this, we could also win the cost sharing on that.
That's an excellent place for modeling.
And on the social determinants of health piece, the way that we've been talking about it is that there are elements that are not really variance in the quantitative modeling because they're harder to put in there, but that are important for the overall structure of a proposal. And so it's not really part, and Jared should jump in, but it's not really part of the actuarial or financial modeling, but that when we have the discussion next time about kind of what are those values, and we've identified what those values are, but we haven't as a group, but folks haven't really had a chance to talk about operationalizing that. What does that look like? That's going to be the focus for elements like social determinants of health. So, Erin, maybe you can, tell me if I'm right about this, but I think that when we're looking at actuarial analyses on this, incorporating social determinants of health, I think, is important in understanding where the savings are when we invest in these programs. So, at least from my perspective, I think it would be important to include.
So this is Jared. Are you saying you're looking for the more societal savings associated with addressing social determinants of health as opposed to just the, I mean, you're going to have some cost in healthcare impact in the short term and maybe longer term, but there are impacts outside healthcare. Is that what you're getting at?
That's what I'm getting at. I mean, I think that it's pretty clear. I mean, the data are out there, right? That the more that we invest on the front end, the less that people have to utilize long-term care because, instances of diabetes or whatever goes down, and that does affect the cost of care in the long run. So in any case, just wanted to put that out there.
Sure. And I think anything related to future years, clearly it would have to be based upon the research that's been done thus far in terms of trying to figure out what kind of economic I don't know if economic's the right term, but societal economic impacts the addressing social determinants through the healthcare system would impact. But I think from just a pure modeling what the universal healthcare system is going to cost, we're looking at what is it going to cost to provide the services based on the structure, based on the characteristics that we're going through today. And then I think the not so much the primary part of the actuarial analysis is to maybe identify and or explore the longer term savings, if you would, or impacts associated with implementing such a system. Did I catch that right, you think?
Yeah, just,
Okay.
Putting with my economist hat on, understanding the externalities, I think it's important to point out to the state over, let's say, like 5-10 years or whatever, how much actually we would save if we incorporated these social determinants of health when doing the modeling. Sure.
Thank you.
So, just thinking about timing and wanting to make sure that we get to more of the questions. Some of the other issues around cost sharing are about so we've gotten some input about having sliding scale impacts for cost sharing, and whether and Erin, some of what you brought up was about kind of whether there were data-based ways to impact health in a positive way through cost sharing and being careful about that. Thinking about whether others have anything to add related to cost sharing being used to encourage, say, use of primary care or getting care in a more expensive setting. Some programs now, it's cheaper to go to your primary care doc than it is to go to the ER because wanting people to get in at an early stage, for example, and whether cost sharing should be tied to evidence-based assessments for effectiveness, whether folks have more to add on that topic.
Yeah, this is Pete. I agree. I think this is an opportunity not only to expand access, but different approaches to managing costs. And, one of the biggest drivers of, I think one of the biggest drivers of cost, is low value care. And there are literally some services out there that actually provide negative value, not just zero value, but negative value. So you look at having low or no incentives for specific services that, like immunizations. I think for many primary care visits, if they include value-based services, you could have low or no incentives. But you could build it in such a way to really steer people towards, the evidence-based care that improves outcomes and hopefully reduces costs.
I think it's the hopefully reduces cost piece that's the, Pete, that's the, to me, the big question. I think that's a, I think the research is very equivocal on that, except in some circumstances.
All right, so we've got Kirsten has her hand up.
I think then again that Medicare and the health benefits exchange can offer a lot of good solutions there on benefit structure. Some of the things that are free to go in for, immunizations, flu shots, annual physicals, those type of things. And same with the Medicare program. There's been a lot done the last several years now on value-based payment options. So I think that could really be a good to look at to help guide that process.
I'm sure most of you guys saw, but we've got about 10 minutes left within this session, and then the next group of SMEs will be coming in to talk about one of the other options.
All right, so there are two topics that you got to talk fast. One is about level of autonomy versus standardization. So if there are health plans, this is something I think Bevan mentioned a little earlier about how many providers you have, in terms of whether there are particular areas of plan operations, provider reimbursement, or benefits administration that you think should be maintained by insurers versus given to the state to really standardize. And then the other big issue is whether folks see this as a transitional model to move toward option A, which is fully state, having no insurers, or whether seeing it as an end state into itself. Talk fast.
All right, so Pam has her hand raised. Go ahead, Pam.
Yeah, I just want to make sure I got this in. This is kind of piggybacking on someone's earlier comment. If this is going to be for a much larger population than, say, served by the exchange now, sort of a similar model, I don't know what we know about the optimal number of insurers, and if it's better to have, someone suggested a smaller number of insurers, that might actually be really appropriate. That seems to me an area of modeling could help inform that discussion of how you would decide, set benchmarks for insurers and numbers of insurers, or for, how the state would be divided regionally. And are you better off having like 2 insurers in each area, or as many as possible? And I don't think I've ever seen data to show what the value is of having a lot more insurers. I know other systems, like in Japan and in Germany, they have a number of insurers, and I think there might be information available and modeling that could be done to show that. You need a certain size population to really get the value of population-based care.
Right. I would also lead towards a fair amount of standardization, especially in setting the amount of money they're able to keep for administrative purposes. If we basically just said, we trust you, do your best, the variation in terms of the amount of money that we utilize in a whole range of administrative costs would be huge. So I think coming up with an actuarial sound standard and specifically how it can be used, I think would be helpful.
Okay, Bevan, you are up.
One thing that's occurred to me too is potentially like a bidding process, right, for private insurance providers. So, the state could, let's say, open up a bid, every 5 years or something like that, and private insurance companies could go in for bid and say you get 3 administrators for the state or something like that. But again, I think that comes down to the population size. If we have too many, then the cost of care is going to go up significantly. I do think that, looking at the ACA, one of the things that has been really useful with that is the standardized plans. And I think that's really been helpful for states like ours to be able to codify that standardization and provide a template for insurers. So I would lean much more heavy towards standardization, at least putting a threshold there and a platform there. And then I obviously am voting for the smaller amount of insurers, the better.
All right, Kirsten has a comment. Kirsten, take it away.
Yeah, I agree with standardization too, for the same reasons, keeping admin costs down and also make it more user-friendly for the public to have a better understanding of what their options are and what kind of healthcare they're actually paying for. And also, I do think it's important to have some competition there within the system. I come from a background of growing up with socialized medicine, and getting the competition out of a process is not always a good thing. So Sweden, has socialized medicine, and I think that can affect quality of care at times, because there's no other option. And where do you turn if you're unhappy about things? So, and what kind of bureaucracy do you have to take on as a private consumer to have a voice? I think those are important things to think about.
All right, Carrie Glover, you're up.
I actually don't have a comment yet, but I tried messaging you guys. Patrick Connor's Wi-Fi dropped and he's been trying to get in.
Oh no!
So I tried messaging you guys, so if you could get him back in, he would appreciate that.
All right, I will get to work on that.
Thanks.
All right. Okay, so Aaron, go ahead. You are up.
So I just have to, Kirsten brought up the business of competition, and I guess I have a different view. It's not that I'm against competition. Competition can be useful at times. But I think what's important is to look at whether market forces in a particular instance helps us attain a goal that we have. I don't think competition is a goal. Competition is a strategy. And I think competition among health plans, I would challenge people to come up with the evidence that such competition has overall benefits for society. I think the choices that people are able to make among providers, medical clinics, and hospitals can be useful, can be beneficial society, as a society, but competition among plans itself, to me, is not, it's not that important. I mean, it may be useful, but in certain circumstances. But I think if we look at the systems that encourage competition, whether you're talking about Medicaid or the exchange, I think the competition, is, to me, on balance, more harmful than good. I mean, you think about it, competition requires people to make choices, for example, every year between health plans. If the health plans have their own networks, for example, in the exchange, you're asking people to make decisions about their providers at the same time. And so you're basically undermining continuity of care in the service of competition between health plans. I don't think that's a good thing, and I don't think the research shows that it is.
Can I get folks to weigh in about the question about transition or end state before I get the hook?
I'll just say quickly, man, if we could get to model 2 and implement it, you know, if it's transitional or the end state, I'm not that worried at that point.
Yeah, I think just from a pragmatic perspective, if we're talking about just the state of Washington, I think it would be financially a hard lift to get to Model 1. So I would be happy if this became the endpoint.
All right, so we're getting a message up at the top here. Our next session is going to be beginning shortly. And again, work group members, you guys will stay here, and then our SMEs will move, and then we'll have a new group come in. So you guys don't have to do anything. So just hang tight.
I just have to find the right button to jump out.
And I think we still have a little bit of time. It was just letting folks know that it was going to be happening soon.
Okay.
So I don't have any other hands raised, but by all means, let's keep it going.
Any last comments on this section?
I'll go. Carrie McKenzie here. In the terms of conversation of the competition and the standardization and autonomy, I know it all plays into the cost. And what we're seeing today out on the exchange and other things is it's not affordable. So the level of standardization only matters if it actually drives down the cost and makes it affordable. Because honestly, we've seen some standardization already, and it hasn't really changed the cost. It just hasn't. In fact, I think costs are going up still. So.
Okay. Thanks. All right. Well, I'm seeing little notes saying that I'm supposed to leave the room, so I'm gonna head out. And thank you all, and have a good next conversation.
Thank you.
Hi, Liz and Chris.
Hi.
Hello.
We're here. Is Jamie in here yet?
Doesn't look like it. But
Okay.
one thing that I did for Nora just this last time was I kind of kept track of folks that raised their hands when they had a comment or they wanted to share
perfect.
something. And then I just called on them, and we just had just a really nice open discussion. So
Okay.
if that works
That's
for the
great.
two of you, I'll do that.
Okay. Jane, I see that you're in here too. Hi, everyone. Let me find out where Jamie is real quick. Otherwise, I'll just get rolling. Jane, I think actually you're supposed to be going back to a different room.
So somehow I don't think I was moved.
You weren't supposed to move.
Go away,
well.
Jane.
Okay, Jane, we can
Thank
give
you, Erin.
We like you so much, Jane, but you already talked about this model. So
I know, well, I'm happy to have somebody move me.
Yeah. She looks like she's
want me
driving to her next room.
No,
Okay.
actually, my husband's driving.
That's okay. I think Jane could facilitate. I was left
Okay.
hanging, so.
Well, do we want Jane, does Jane need to go back to the other group?
Yeah, Jane, the best way to do this, and I'm sorry for the complication, is, and I hope you can do this on your mobile device. If you can see a button at your bottom that says leave room, click on that.
Well, I see a button that says room 1, and I see I'm doing this on an iPad, so it might be a little bit different. Or leave the meeting entirely.
Don't do that. Don't leave the meeting entirely.
Leave the whole meeting.
Liz, how about will you text?
I'm taking care of it. Yep.
Okay, wait, I'll go ahead and get us started so we don't lose any time. Hi, everyone. I'm sorry I'm late. I didn't get moved. So here I am. I managed to get beamed in to see you. It's nice to see all of you. I'm going to give us our little preamble here. We're going to talk right now about the fill the gaps model. or the close the gap model. I'm not going to repeat everything that you probably heard the last time around. You're going to get to talk about all three models, but right now we'll focus on close the gap. And I'm going to ask you some specific questions related to this model only. And again, you heard this before, to make sure that we walk away with as actionable information as possible, I'm going to ask you to be really specific in your feedback and answers to my questions, which I know a lot of you, I'm not concerned about getting specific feedback from you. I'm very excited to hear your thoughts on this. So let's just dive right in our now 27 minutes together. I'd like to start by hearing your initial feedback on the close the gap model. What was your reaction when you saw this, or what are your initial thoughts? And please raise your hand if you'd like to contribute here. Wow, that was a fast trigger hands. I'll start with Carrie McKenzie.
Well, my first initial impression was where is it improving anything? It didn't seem like there was a safety net. It didn't seem like there was cost controls. It didn't seem to reduce the administration costs. So I was hopeful to hear more about it, because obviously there's probably still something in there that helps over what we have today. But filling in part of the gaps didn't seem to address having a comprehensive plan that I could count on.
Okay, and so your feedback is very consistent with what we heard in our previous discussion group. Let's go to Bevan.
I have a feeling you know what I'm going to say already, Jamie. I don't want to look at it at all. I almost don't even want to spend time doing an actuarial analysis on it at all. I would much rather look at some of the framework that was written into the budget proviso about a multi-state idea, and spend money looking at that. This is, the state is already spending money on Cascade Care and premium subsidies and, pretty much everything that's written into this option. So let's spend our resources wisely and not deal with this one.
So it sounds like your request right now, Bevan, would be to scrap this one altogether and look at something different. Okay.
Yeah. I
Okay.
mean, because we're missing, part of what we're missing here is like what's actually written into the budget proviso itself, which is to look at, what something like a multi-state solution would look like. So I don't see that in here at all. And so I would rather spend our resources looking at that than Cascade Care again.
Okay, so your specific feedback would be to replace this one with a multi-state coordinated option. Okay, Aaron.
Yeah, so I think we have to look at this option because this is sort of the status quo. And one thing that we've never done well in this state is to estimate the expensiveness of the status quo. And the status quo is the most likely outcome of this whole, political process. Getting to universal coverage is an uphill battle, no matter what the political divisions are in the legislature or who runs the governor's office. It's a big lift, and one of the things that's important to me is that as we estimate what Model 1 or Model 2 would cost, that it's clear what the status quo is going to cost. And I'm very confident that the status quo will come out much more expensive. And that's really critical if we want to provide good evidence to policymakers about why they should stick their necks out and move us towards one of the two universal models. So I don't like Model 3. Model 3 is what we've been in this mud for decades. But I think it's essential that it be part of the mix.
So Aaron, it sounds like your justification for keeping this model in is to be able to get a clear baseline, a clear understanding of what the status quo is and what it costs.
Absolutely.
Okay, Chris, really quick clarification question, because my understanding was that we were going to be comparing all of the three models to the status quo. Is that accurate?
Yeah, that was my understanding as well, that the three would be compared to the absence of any of these, but to Aaron's point there is value in showing how, you know, an incremental improvement costs this much and a significant improvement costs something slightly different, you know, and kind of having that all as a comparison point.
Okay. And I apologize, I'm not sure who rose their hand first. I'm going to call on Shaston and then Pam. Shaston? Do you need help unmuting? See if I can unmute you here. There we go. Nope.
Sorry, I forgot I hit the mute button there for a bit. Yeah, I agree with the team fully. I don't like this option, but I also think it's important to keep it in there for the reasons that have been mentioned, and both to show that how much more expensive this will be and how little it'll change anything, and get us to a more affordable and accessible healthcare system for the state of Washington. My also thought is that I think the way the political climate is, I think it's going to be really hard just using that term universal health care for people to relate to this and really understand what it is. I think a lot of the misinformation that will go out there will be about higher taxes and how unaffordable this is going to be for folks, and what a horrible thing it'll be for the economy, because we're going to be fighting the whole insurance market going out with something above, and also a lot of unions and interest groups that are heavily involved in, I mean, we're going to look at a high unemployment rate amongst a lot of people, for one, which is going to scare people too. So, and also with Affordable Care Act, I think it's important to have something in place if that were to go away, because this to me reminds me of the basic health program. And with Cascade Care, there's something there within the state for people that end up without health insurance, especially single adults, that can be at least give them some access to primary care and some basic health care needs. And basic health program was really a lifesaver for a lot of working poor and low income people in the state of Washington.
So Shaston, it sounds like you're echoing that this does need to be kept in for some of the reasons Aaron also articulated, but you also see it as potentially a stopgap, that there are maybe some benefits. Pam, how about you?
Yeah.
Thanks. I think that you need to keep this in for a lot of reasons. I think you need to do the model justice. I hear a lot of misconceptions from people when they talk. One is that Cascade Care has been funded. Cascade Care is not funded. Subsidies have not been funded. There's been no money for those things at all, which is why one of the reasons that premiums are so high. The other reasons that premiums are so high is that there's been a systematic effort to undermine the Affordable Care Act, which has increased premiums by 40 or 50%. And they were coming down prior to 2016. So I don't like our system.
Yeah, so
I don't think anybody likes our system. It's, you know, it's got so many flaws and problems. But the other models that we're talking about are very difficult. The path there is really hard for me to see, even though I think both things, the models we're talking about, are superior to our current one. Therefore, we are stuck with continuing to improve what we've got until we can get to something better. And I think just saying, well, we've got Cascade Care already, or it can't be fixed, is kind of a cop-out. I think we kind of need to look at what are the gaps and how could we fill those gaps. There's huge problems, I think, related to undocumented for people, for affordability. You know, we have cost sharing reductions that are unfunded. You know, there's lots of things that need fixing. We also have huge cracks between programs for people who are in Medicaid for Medicaid fee-for-service versus Medicaid that covers other people. Why is it that women can't stay in Medicaid for a full year after they have a baby? I mean, these are many, many things that are not, you know, individually, they're not exciting, but if you can fix all of them, you can make a huge difference for a lot of people. So I think it needs to stay in.
So Pam, it sounds like you see some pieces of benefit to keeping this, and I'm hearing some some general interest in keeping this. And I'm going to want to move us on so that we have enough time to cover our other questions. So I'm going to ask Carrie and Bevan, who both have your hands up. Do you have anything to add to what's been said, or is it more of an echo? And I'll call on Carrie Glover and then Bevan.
I was going to echo Pam. I think
Okay.
a lot of what Pam just said, spot on.
Cool, thank you. And Bevan, anything to add or echo or something new?
I was just going to clarify that by saying funded, what I meant was the research is being funded, and so the commission is already gathering and doing that research. And there are actually folks in this work group who are also doing the Cascade Care research. So I guess my point was that the state dollars have been allocated to the research to see how we can fund Cascade Care. So I just wanted to clarify that.
So if the analysis, in other words, if the analysis is already being done for Cascade Care, why would we do it again here? Would that be a duplication?
Right, or we could also share information, right? These two work groups would, we could probably benefit from each other's research and share information, but allocating the small amount of funding that this work group has to kind of duplicating that effort, I don't know.
And my understanding from the Q&A, and I can't go into depth on it, but maybe we can provide more follow-up, is that there is going to be sharing of information across the work groups and a concerted effort to avoid duplicating duplicating the analysis. So
Yes.
do you have anything to add to that, Liz, before I ask my next question?
No, but that's,
okay.
We're planning to coordinate and align with the Cascade Care work group.
Excellent. Okay, so next question is, should this model be open to all Washington residents regardless of immigration status, and why or why not? And the specific reason that I just want to give you a little context for why I'm asking that question here, because this was also asked more generally of you when you did the survey, is the Affordable Care Act only allows US citizens and documented immigrants to purchase plans on the health benefit exchange, even if they're using all of their own funds. So even if subsidies are not involved. And so if a program like this included undocumented Washington residents, there would have to be some kind of separate administrative modification to allow those residents to buy off the exchange. So Aaron, I see your hand up. What's your thought?
So if COVID-19 has taught us nothing else, it's that we want to make sure that everybody in our community is able to go get care, seek attention, if they're concerned about them, their own health, the health of their families, their whatever. I don't want to go to a grocery store in which I have to wonder whether the people I'm, rubbing shoulders with are able to get care for their slight fever. So to me, this is just, it's such a clear lesson that we should be learning right now, that coverage for financing for healthcare needs to include everybody in our community, period.
Okay, so it's not just a matter of looking at the cost of adding undocumented Washington residents to this, it's also understanding the cost of not adding them.
Yeah, Bevan's point before about social determinants. So immigration status is a determinant of health, and universal coverage, real universal coverage, is a way to reverse that bad determinant that we have in our midst. So yeah, absolutely. This is about societal costs.
Okay. And so everyone knows too, I understand this, and Chris echoed this in our last discussion, the actuarial model will be able to show us both outcomes if we add undocumented residents and if we don't. So we'll actually, this is kind of a decision of whether or not we actually get to compare costs and outcomes. I see Shaston's hand. Shaston? Uh-oh. Oh.
You want me to unmute her?
Let's see if I can unmute her. Just a
I
second.
unmuted her.
Oh, you did? Okay. Too many of us trying. There we go. Okay, got it.
Remember this. Wait till meeting 5 when I have this down.
Oh, we're all going to be so good at this.
Muting. Hey, no, thank you, Aaron, for bringing up that important point. I agree. I think we need to look at the health impacts of who is covered and who is not covered. The other part, there's so many political and economical forces behind that that are way out of our control. But I think we need to look at the overall health of everyone that resides within the state of Washington, whether here legally or what's considered illegally. So amen to you, Erin. Thank you.
Thank you, Shaston. And Carrie, and then I saw Dr. McGough raise his actual hand there. So I'll take Carrie McKenzie and then Dr. McGough.
Sure. I'd like to clarify. I mean, when we say, are they covered, should we actually be saying, are they participating? Are they allowed to participate? Because that would assume they're also paying premiums and they're also, participating in the cost sharing and that, regardless of their legal status. Because I think when you say they're covered, that means for some reason it initiates, oh, they're getting covered for free. And what we're actually saying is, are they allowed to participate?
Right.
I mean, no more or less than if we say you're covered, that doesn't necessarily mean it's for free.
Yeah,
it just means you're
allowed.
included.
In the pool, or are you not? Might be a better.
I agree, but I'm bringing up the idea that for some reason it conjures up the undocumented status that they get everything for free. And it would be better to say they are allowed to participate or not.
Oh, I see. So the language matters here. Yeah.
The language matters is what I'm trying to say.
Yeah. Dr. McGough?
Yeah, I want to put an exclamation point at the end of Erin's comment around the impact on health. If we don't include undocumented migrants, it is going to really have a negative impact on our overall state health. The COVID example is, I think, the most recent, but there are plenty of other ones. When you look at tuberculosis and, many of the other preventable diseases, just as one area, the health risks and the associated costs are immense. And the idea that, they also pay taxes. And so to the extent that, they're participating in a state program, they've helped pay for that program. Yep. So, but I would just say from a pure health and self-interest standpoint, would be crazy not to include them. I realize that political hurdles are significant, but this is where education comes in.
Well, and the good news is at this point, we're just making the decision about whether or not to look at it in the model. We don't have to start fighting the political battle until later in this process. Yeah, Chris.
And yeah, a quick comment about the model. Models are typically very good at looking at increased costs, like the premium subsidies or cost sharing subsidies that might go along with allowing undocumented immigrants to participate. We can also definitely look at reductions in uncompensated care, kind of some of the cost offsets that you'll generate if you do include them. One thing that models are not as good at is the societal health concept. So I think that's just something to kind of keep in mind as we move forward, is ways that we can quantify that to help add that to the argument and make it a truly fair comparison of scenarios with undocumented immigrants and scenarios without undocumented immigrants. Because I think what we're all hearing is that it's going to be in the state's best interest to include them, and then it just comes to us to make sure that it's a fair comparison when we're providing the analysis that can be used to support that position.
Thanks for that clarification, Chris. Okay, I'm going to want to move us on pretty shortly, but I see two hands up. So again, I'll ask the question, are you going to be echoing or adding? And we'll start with Bevan.
This is just a general comment, which is that I think we are sitting in a moment unlike we've ever seen in our history. And so I think catalyzing this moment when we have kind of a microscope on our healthcare system is really going to help push this forward and open people's eyes to, how broken it currently is.
I have heard that feedback quite a lot, actually. You are not the only one raising that point now. Shaston?
Yeah, just another comment there to add that I think there is that opportunity right now to look at the migrant impact in Eastern Washington on the overall economy of having that population driving so much of the increase in infection rates. So hate to use COVID-19 as something that could bring in additional information that way, but I agree. It's a unique opportunity right now to highlight some of the cost of leaving certain segments of the population outside of access to healthcare.
Thank you, everyone. And I heard some really good, consistent feedback there that'll be really helpful and very specific feedback. Let's move on to my next question, which is, should this model, now some context here, the Affordable Care Act, as you know, if somebody, oh gosh, we're down to 5 minutes. I better speed up. I thought we were going to get warned before that. The Affordable Care Act, if you have access to employer-based coverage, you don't get to buy healthcare on the exchange. The question here is, should this model allow those with access to employer-sponsored insurance who, where the cost sharing for that insurance is not affordable to them, should this allow those folks to participate in this model as an option? And since we only have 5 minutes, I'm going to ask everyone to just kind of give me your quick yes or no and why on that. Any feedback on that one? Shaston, are you raising your hand?
I'm going to say yes.
Okay.
Yes, I'm going to say yes. I think they should be able to participate.
Oh.
And I think that ties back to our first discussion too about employer participation and cost shares. I think it has a real financial impact for residents in the state of Washington, how much employers are paying for healthcare right now.
And that is very consistent with what I heard from the other group. Aaron?
I agree.
Appreciate your brevity there. All right, I'll take Pam and then Dr. McGough.
Yes, I agree. The family glitch has just hurt people very badly.
Okay. So it sounds like a lot of agreement around including these folks. Dr. McGough?
I agree as well. And the only concern would be what some employers might do to get employees off the roll. But frankly, I don't see that as a bad thing.
Okay. And we haven't gotten to hear from Patrick yet. Patrick, hi.
Hi there, back after unintended hiatus.
Thank you for all the work you did to get back on.
Hanging in there.
Well, I think there's a lot that can be said about the value of employer-sponsored health insurance. We do need to be cognizant, though, that whatever system we set up, that if we're trying to de-link health insurance from the employer relationship, there's going to be additional hurdles which will take more time and add more cost and effort here in the state. So I think we at least need to have a little bit of note there that we are aware that things like ERISA, Taft-Hartley would come into play. And in addition, when you talk about the affordability question, are we simply talking about the affordability question as it is defined in the Affordable Care Act? Or are we talking about an individual's perception of what's affordable based on their income and other expenses? So we do need to, I think, be mindful of those nuances. What is in federal law, what is able to be overcome, that might be restrictions in federal law, and how that would impact our ability to develop some kind of state-specific program.
Okay, so Patrick, sounds like you're raising a couple of potential unintended consequences or consequences we might need to look at with respect to employer-sponsored coverage. So thank you for raising that. And then Carrie Glover, last thoughts?
Yeah, I mean, I generally agree as well. I think when we look at especially chronic disease patients and stuff, they don't often care so much about what health carrier they have, what their health insurance line is. They care about what providers they can access. And don't want, starting a new job and having that provider offer insurance that doesn't allow them to have access to the provider that they want, have that be a barrier. And so I think having that kind of flexibility is in general a good thing. I also think it's not that simple. So I think Patrick's points raised are good ones, that none of this is ever as simple as it seems. But in concept, I think, giving people the freedom and flexibility to get the plan that helps them access the providers they need and want is a good thing.
And I want to also just make sure I called out the other point that Patrick made about affordability, that it's not that we need to be clear what that means. And there's a specific affordability threshold that if someone falls under, they're eligible, rather than someone's individual perceptions of affordability. We're running out of time here. So I'm going to ask Carrie and then Bevan to make some final remarks. And then I think we might get beamed out of here. Carrie?
We're going to get beamed out, but they have a 5-minute stretch break.
Yeah.
Okay, real quick. I just wanted, because we were talking about removing the employer piece of that, which is the best part of that is that you could have continuity of care. Because right now, every time you move employer, you may have 1 to 3 months before you're actually covered, even though you're employed. So what would you do, or how are we modeling that gap between changing of employers in some of these models? Especially number 3.
Chris, do you have any quick response to that, or is that more of a follow-up kind of thing later?
Yeah, I think we'd have to follow up on that later because that would take some complex modeling on that.
Because technically you are employed, but your coverage hasn't started yet. And you have a gap of insurance unless you take COBRA from your previous employer.
So Carrie McKenzie and Patrick are raising some complications we need to address here. Bevan, I think you're going to get the last word before the stretch break.
I just want a point of clarification in the models. Are they going to include money for just transition for any kind of training that would need to be implemented for, making sure that we're keeping with the unions and what they need for just transition?
Yeah, I'm not sure about that. I think we'd have to take that one back and think about that.
And Bevan, this is just off the top of my head. I think we need to make a note and follow up, but that may also be a policy consideration that we put in the final report as something that needs to be addressed. All right, we're about to take a 5-minute stretch break. So you can feel free to turn off your video camera for the stretch break. If everyone could return to your screen promptly at 2:45, we'll get started with your final breakout discussion group. Thanks everyone, it was great to see you.
Bye. I'm telling
Hey there, Janine and Shane.
How's it been going?
Hey there.
It's been going really good. So one thing that I've been kind of helping out with, and you guys let me know if you want to do this, you know, as folks raise their hands and they want to share, they want to comment, do you want me just to kind of be responsible for that list and kind of calling out folks as we're ready, or would one of you prefer to do that?
Well, now that I understand how the hand raising works, I have sort of been calling on folks, but what would help was Betsy had helped me make sure I wasn't missing anybody.
Okay, I can do that.
Okay. I'll wait for a few more participants to get back and join us. Well, I don't know if everybody can hear, and we should go ahead and get started because I know we have limited time. I'm Janine Smith from HMA, and Shane Mulford from Optimus is joining me, and our discussion is around option A, the universal coverage model with state administered. And hopefully you all have had good discussions on the other version of this, which was with the delegated authority. So this is one where the state would have all Washingtonians eligible. The state would define the package. It would set the rules for the delivery system. It would not have a health insurance carriers between them and the providers, but would directly contract with the providers. And then the variation would be to exclude those who are in federal programs such as Medicaid and Medicare and several others. So I don't know if there are some initial questions you have about this version of the universal model. I have a series of some questions that you may not have touched on when you did the other version that I wanted to ask you guys. But I'll stop for a minute and see if there were any questions about the straw structure of this particular model. Dr. Katz?
Just Aaron, thanks. I actually had a question. I had sent this to Jamie at the very introduction of our meeting, is just understanding what the staff were thinking about in the models in terms of the federal programs, so Medicare, Medicaid, who are served by the Indian Health Service or by tribal governed clinics aren't mentioned. My understanding is that the state, since it's a federal trust, the state can't force those folks to become part of a state-run program. And I'm just wondering where they fit in in terms of eligibility with that caveat about federal programs.
So Shane, I don't know if you want to get that one. I can also augment.
Yeah, that'd be great. I mean, that's a really great question, and that's actually one of probably the bigger challenges with the model when you're thinking about universal coverage is that we have such a fragmented, not just payer source, but the regulatory framework is. Jimmy, could you? Thanks. We have a really fragmented regulatory structure as well. So one of our questions for the work group members is which programs we should be trying to go after to fold into the model in terms of Medicare, Medicaid, and obviously some of them have much greater challenges to fold in. So I think initially we're trying to model or you at least pull in Medicaid, but to the extent that the members want us to model further, we'll look at that. But I think that there are some pretty serious consequences in terms of the implementation timeline, the work that you would have to get or the statute would have to change in order to pull some of those programs in could make it much more difficult to implement the program.
Well, I just say that the tribal and IHS group is different, certainly than Medicaid, different than Medicare. So they're separate. There's a federal trust responsibility, and so I think an important question. I don't have the answer to it. I just think an important question is how we, in the modeling, in the policy design, we consider the inclusion of, say, tribal or traditional healers, etc. Just to say that, because since they weren't mentioned in that parenthetical in the models, I just wanted to throw that out there.
And a lot of the IHS dollars are not, it's not an insurance plan per se. It's dollars that go to the tribal clinics, the systems, and so it is often treated very differently when you're thinking about universal coverage models. So as we discussed in our first one, Bevan, you wanted to add?
Yeah, I just want to hop in a little bit because I do work with the American Indian Health Commission very closely. And this is an issue that came up when we were helping to draft Pramila's State-Based Universal Healthcare Act, which is that really the tribes want to be excluded but not included. It's each nation is their own nation. And so, you can't have a one size fits all. So, you might have the Ho that don't want to participate, but the Muckleshoots do, right? So I think making sure that, any modeling goes through the American Indian Health Commission. And so they can help facilitate, the wording and the modeling that goes into that. I know that they are supportive of a state universal healthcare system, worked very closely with them over the last few years. So, and just, yeah, as you mentioned, Janine, that, IHS is just really a payment as administrator essentially, but that each tribe has their own healthcare system that they've set up. So they're each unique in their own delivery.
And this question kind of then leads to the question of mandates. The groups is, do you have a mandate for this kind of model? Or is there some, more a la the way it went with the Affordable Care Act? Or is it more like a Medicare where you're eligible, as one group said, at birth? So what are the feelings of this group in terms of a mandate being necessary? Go ahead, Aaron.
So what I would say is that this is a question of timing. So I would think a mandate in the beginning would probably be necessary, but my, sort of ideologically, I'd like to get to the point where, if somebody has a residence, is a legal resident of, I mean, not a legal resident, is a resident of the state of Washington, that just means they're covered by the program, the same way that we're covered by the police and the fire department in the community that we live in.
Yeah. And Carrie, did you want to add in?
Sorry, I hit raise hand instead of unmute. I think the one thing I would add in on the mandate is in Washington we have, whether or not it's a good idea is very different than whether or not it's feasible here at all, because we've been having this conversation since the individual mandate was repealed, and we don't have an income tax, so we have no way to enforce this. I don't know if that's
Yeah, that came up in the other.
So yeah, I mean we have major feasibility. So I mean, I think it helps people get started. I think it was like I think that was Aaron just saying, like it's a good launching. It gets people signed up. It gets people bought into the system. It gets people going by starting with that requirement. But we haven't figured out the hook here. So.
And it looks like Patrick, you wanted to.
Yeah, thanks, Janine. I think a good portion of this question is answered by the funding mechanism that's being used. If this is going to be funded primarily by things like premiums and some type of cost sharing, I think a mandate is necessary in order for that kind of model to work. If instead there's some way of financing it through, say, general taxes, to follow with Aaron's line of thinking about police and fire coverage being universally available, then that's a somewhat different question. And I think one area that we've also not had a chance really to dig into much, unless you did so when I was briefly offline, is whether or not there's some type of time period in which somebody would have to establish residency in order to help to ensure that we're not getting transient populations coming to Washington for expensive care on somebody else's nickel and then leaving the state again once that care is complete. So that magnet effect of bringing in sicker populations that find out Washington you can go and get it for free, whatever that means, is something that also needs to be thought about as we move forward developing this plan.
Good. And then Bevan?
I just wanted to put something on the table, which just occurred to me. Is there any appetite for, just auto enrollment and then an opt-out option?
Well, that raises the question that I also wanted to lead into, which is there options for folks to buy supplemental insurance to complement what might be offered through this new universal model? Are there options for people to, it sounds like some groups didn't think that anyone should be substituting by buying their own insurance separately because you wouldn't want a shift of those who could afford that, and perhaps that there might be some unintended shifts in risk. So just thinking about this new system is in place, is there other market still around it that is allowed? Looks like Kirsten has a.
I think the question of, whether people should be able to buy supplemental insurance is also going to be linked to what the scope of benefits are going to be. I'm thinking specifically about long-term care and those type of costs, vision care, possibly dental care. Are those going to be included or not? And if they're not, then I think there should be some option for people to purchase coverage for those type of services if they want to. I think that a big problem with this too is how ready the public will be for some kind of state-run universal health coverage too. And that's something we need to keep in mind. How would we market that? And then also require some kind of mandate for people to participate in this. I just don't know how feasible it is right now to get something like this to move forward.
Sorry. I just, Shaston, I just echo what you said about the ability to buy coverage that's not included is dependent on the comprehensiveness of the package that is included. So I would echo that. And by the way, I think there's a good political reason to allow people to buy to buy additional benefits maybe, like the National Health Service, you can buy competing health coverage. There's a political region, which is it provides a way for people who are reticent or resistant to the notion of a universal coverage thing to opt out politically. So, you buy something else rather than attack the system.
Bevan, you wanted to add to this? And then I had some questions about benefits.
Oh, great. I was just going to say, I think it's high time that we include vision and dental in any plan that we're going to propose. Our eyes and our mouth are part of our bodies. And I think, the fact that we've had this fractured insurance system has really actually added to the cost of our healthcare in this country. So I would just suggest that any models that we're proposing include dental and vision. And am I incorrect? I feel like our legislature passed a long-term care program, a state-funded program. What was it, 2 years ago? So I don't know if we want to, assume that that's going to continue and then base this next model off of that.
Legislation passed recently, and it's not yet implemented, but there is something there to help for those benefits. So we've had discussions in both of the previous groups. Many feel strongly that long-term care should be in, but then acknowledgement that is very expensive, and some asks of our actuaries that maybe they could price it with and without, knowing that there's this backdrop of some new additional approaches to long-term care. Right, Shane?
Yeah, and I would just note that the scope of that legislation is somewhat narrow in terms of who's eligible for the benefit, how much it covers, and when they qualify for it. So certainly when we're talking about kind of universal coverage of long-term services and supports or long-term care, even the scope could be different on that one too. But it's possible, perfect world, we have a perfect system to implement that we could use the financing that's going into that to support this. So it's certainly something to consider.
And Patrick has his hand up.
Thanks. To address a couple of Bevan's points, and Aaron's on the opt-in, opt-out. Again, depending upon the financing mechanism, having an opt-out approach could pose some challenges, particularly if it is a premium or cost-sharing finance model. Once again, I think we would see those with the best resources and the fewest health conditions choosing to opt out, like we do with the young immortals now, or others that are able to get their own type of care outside the traditional system, doing so under this, which would undermine both the pool and the financing mechanism. And in terms of long-term care, Shane's right. The legislation that passed here provides a $36,500 lifetime benefit, and there are some pretty severe hurdles in order to qualify for it. But since it is a new payroll tax that's being implemented, it might be a potential portion of a funding source depending upon what the financial mechanism looks like to support this effort.
And so we seemed like from the previous discussions as group and also through the survey, those who responded, the Essential Health Benefit Package of Washington would probably be the basis of this coverage. I'm hearing from Bevan so far, adult, dental, and vision. Others' thoughts, the other, and long-term care, we've had some discussion. Also alternative coverage care, such as chiropractic, acupuncture, et cetera, comes up as well. And I know you have an any willing provider clause in your statutes, but just thinking about the pricing of the benefit package, we wanted to have some discussion about what your thoughts were around some of these, such as adult, dental, and vision, because our understanding is the EHB only has children covered for that. Aaron's hand is up.
So to me, I think our goal should be for this program's benefits to include the full range of services that are potentially beneficial to the health care and I guess health of people. So, and in terms of chiropractic and things like that, you know, the Healthcare Commission 20 years, or what is it, 30 years ago now, the tact it took was to define benefits in terms of the services, not the providers. That is, it's not a question of, you know, whether chiropractors should be paid as providers under this thing, but rather whether care for, you know, back injury or back pain is covered. And there is a genius to that, which is rather than to have this effort devolve into a battle between turfs, you let those turf battles continue as they have for decades in the legislature. And I'm definitely an advocate of that approach.
Question would be how you might, so then if the state would then contract in this model directly with providers, so they would see who wanted to join and be part of the provider network, correct? I know that the current system, the provider networks developed by the health plans sometimes restrict that, so you don't get, I don't know, some more obscure treatments necessarily being offered by your network providers.
So the battle is over scope of practice. So if the legislature says that a certain type of provider is legally allowed to provide a service, that's a pretty powerful, you know, stamp of approval. And then, you know, then the state is, you know, let's say it's the healthcare authority, whoever the state, you know, the lead on this thing is, you know, then their job is to find legally licensed providers who are willing to provide the service that's covered under the program for a price that the state is willing to pay.
Can I ask a follow-up?
What others, or Shane, you had comments?
Yeah, I'm just trying to think of that from a modeling perspective. Sorry, I didn't realize it could be a little difficult here. Janine, could you put your, I don't know why, but you and I have weird connection. So my question from a modeling perspective is, it's easy to think about a series of new services that you could price out and throw into a model. I don't fully have my head wrapped around this concept. I totally agree with you in concept. I'm just trying to think of what should we as the actuaries expect in terms of any potential additional utilization that we'd expect under that definition. Is there any insight you can provide? Because I am totally with you in concept, but I think when I go to try and model this, I'm going to get lost.
Well, I mean, just briefly, and I'm anything but a modeler, so I don't know diddly about that, but I would just say, first of all, we have a list of healthcare providers who are licensed and they have scopes of practice. I would use that current list as a proxy for a benefit package that doesn't define benefits by provider type. So I think, you know, I would say the best you've got is what is our current experience.
Patrick, do you want to get in on this discussion here?
Yeah, just briefly. Again, if we're to move to a new structure, particularly one where the state is making contracting decisions, then our existing any willing provider legislation, I think, pretty well covers what would be within the existing medical health benefit package. And I'm not sure that you need to model much more than that. To Bevan's point, I think it would be helpful, interesting to learn what the additional cost might be for full vision coverage, full dental coverage. But rather than bake that into the model itself to avoid sticker shock, I think it might be helpful to break out those categories so we would know what the upcharge, if you will, might be for including vision and dental, so that we get a better sense of what a truly universal package of benefits could look like under a universal care model.
Yeah, and a point of clarification on that, the way that we're structuring the entire model is to have it be dynamic, such that we can pull things in and out based off of these incremental decisions, either on benefit coverage or For example, if we wanted to pull in employer coverage or carve it out. So given that it's dynamic, we should be able to inform those conversations without avoiding kind of that global sticker shock. So we're with you on the same page, for sure.
Perfect.
And Bevan?
I was just gonna ask, kind of in the same vein as Erin and I think a couple other folks in our last group discussion had about including option 3 because we wanted to see the cost associated with the status quo. Can we also do that with vision and dental? Can we say if we don't include that, you know, what's the cost of not including them, I guess is my point. And I understand that might get a little complicated because those are externalities, right? And that's talking about like, you know, 10 years down the road, if we continue with the status quo with having X amount of adults not covered in terms of dental coverage, like what are the long-term costs to the state if we don't include that?
And are you referring to things like the emerging body of evidence around dental care being linked to heart health and then some of those ancillary costs that would be associated with not covering the benefits in the short term?
Yep. Yeah, I mean, because we know, right, that plenty of adults who don't have dental coverage end up with long-term, you know, debilitating chronic issues in the rest of their body because their mouth was unhealthy, right? So I think that, you know, demonstrating the long-term cost or savings would also be really helpful.
I just point out that I think there's research to show that there are short-term costs as well. So there's a fairly high percentage of emergency department visits that are related to problems with the mouth. So I don't think it's just long-term.
And again, you have in the essential health benefit package, there's children or dental and vision. So it's just adults and it does have a higher price tag. Are there any folks that I know, Christine, Brenda, Carrie, you guys and Peter, you haven't weighed in on any of this model. Is there any thoughts that you want to add in the last remaining minute before we suddenly disappear into the large room? No? No? Any other, or Pam? Yep, Carrie?
Okay, I mean, I'll just bring this up because I brought it up on option 2 as well, which is the cost sharing. I want to make sure that the employers are, that employee benefits are based upon benefits plus salary, that when we make a change, what is the impact to the employee? And what are actually employers now paying into this? And I want to make it very clear what we're transitioning from and what we're transitioning to. So that employees know they're not losing a certain dollar amount, it's just transferring in different directions, type of thing.
It looks like we have Kirsten Powell has had her hand up if we have time.
I just wanted to add to the ER comment there that was one of the main reasons that the healthcare authority with the Medicaid program reinstated the adult Medicaid coverage after we took it away because they got impacted so hard on the emergency room visit side. So that's some data we could look at to justify including dental for adults.
Yeah, certainly even a more challenging population of costs. So we really appreciate your input. I think we're going to be moving back to the large room to kind of share overall themes from on each of the straw models to help inform the further discussion. And I think we will be evaporating here in a few minutes as we all go back to leave you should all see a note that says leave breakout room, and that'll take us back.